my talk is on treatment options. So we are here to support the patient struggling with infertility. And my role as a doctor or an infertility specialist is basically to give them options in terms of treatment and walk with them through their journey. So the first slide was really depicting a shared responsibility. Usually I see the woman coming into the clinic, and sometimes we don't see the man, and sometimes we see the man at the end of, and sometimes we see the man at the end, or we never see the man. So as Professor Koigi has rightly said, women and men share the responsibility of infertility. It's equal. And anyway, remember, it does really take two to tango. Yeah? It does really take two to tango. So infertility knows no gender, really. The next slide, please. Next. I will go back. Yeah. Sorry about that. Okay. So infertility knows no gender. So what are the causes of infertility? I think a lot have been said about the causes of infertility, but I just want to stress that this is a busy slide, and it's busy intentionally. There is no one diagnosis. There are so many causes of infertility. The ones that are a bit bold are more common causes of infertility, and it's important, therefore, if there are so many causes, for us to investigate. So these are a few slides showing the investigations that a woman goes through. And interestingly, I have 3 for a woman and 1 for a man. So women, honestly, we have more burden. And this is my plea to men. Please show up. We need to also know your sperm parameters because they do count. So for women, we check the tubes, we check the uterus, we check their blood or hormones. And for the man, it's just a semen analysis and the diagnosis is made. So please, support your women. I did one of the roadmaps, but sorry, this is not going well. So one of the treatment options is ovulation induction. And what this simply means, I put a slide there depicting the uterus, a scan. And that scan shows 3 eggs on that side and 1 very big egg on one side. And this is simply put what ovulation induction is. So this is the first line of treatment we give patients, if that's your problem. So we want the smaller eggs to reach the size of the bigger eggs so that it can ovulate. And it just simply is done by either taking some medication or taking in injections, and we're able to help or assist the woman to ovulate. So that's ovulation induction. Then there's something called intrauterine insemination, and a lot of people come to ask me, oh, what does this mean? Is it like the cow, the one that people do in the cow? It's artificial insemination. It's similar. So here what our objective is that we get the man to produce a sample, we wash it, we give it increased motility, and then we insert it into the uterine cavity. And the reason we're doing this is to support the men who have low sperm counts and sperm counts that are not, or sperm that are not moving too fast, to facilitate them to have a shorter distance to reach the point where ovulation is going to, fertilization is going to occur, which is in the fallopian tubes. This treatment option, though, is not for everybody. If you have blocked tubes, this won't work. If your sperm count is too low, this won't work. If you have fibroids in the uterus or other things that are interfering with implantation, this also won't work. So that's the second option of treatment that we support our clients with. The third option is IVF. And I think this is the big thing in our society. People are very, very scared of test tube babies. And I think it's because we don't understand what it is. But it's simple. IVF means just that we're going to take the gametes, the sperm and the ova, and fertilize them outside the body. So it's not magic, it's not It's just normal science. So for this, what we usually ask the woman to do is come into the clinic. We'll give her injections for about 10 to 12 days. Once we've done that, we have a lot of eggs. We put her to sleep for a small operation where we extract the eggs. We actually suck the eggs from the vaginal cavity and we put them in a petri dish. And the embryologist's role then is to have a look at their eggs and put them with the sperm. So the man will have produced a sperm sample at that point. And then they're put in an incubator and allowed to fertilize on their own. But what's the difference here is that we facilitated the conditions of the fallopian tube. So it's quite similar to what's going on, but now just in an incubator. So it's quite simple. And then 3 to 5 days later, we have looked at the embryos that are growing and decided which ones are best, and then we re-implant them into the uterine cavity. And that's it. And we pray for implantation at that point. And 2 weeks later, we have hopefully a positive pregnancy test. So that's all IVF is. I know that it's a very emotional journey. It's very financially, it has a high financial burden, but it is sometimes the only treatment option for patients. Some who have blocked tubes, we're not going to be able to circumvent. So this is the best option for patients with blocked tubes. And some patients who are older and their egg quality is not good, or for some men who have very poor sperm counts. Now with this IVF, there is also a method of treatment that is ICSI. And ICSI basically is where we inject a sperm directly into the ova. So this is part of the IVF, but only is necessary when there is very poor sperm quality, where we just need to get one little sperm and inject it and assist in fertilization. So this is a bigger, more technical, but it does work. Sorry, the slides were placed a bit normal. So what I want to say is this is basically a diagram of what happens to a patient who comes in. I will stress lifestyle because, as Pauline said it, and as Professor said, lifestyle has a high impact. We sometimes just need to lose 10 kilos and the woman will come back pregnant if we are obese. Some patients with poor sperm count, all we do is ask them to stop smoking, stop drinking. We're into shisha now and all this mira and all these other chemicals and toxins that are poisonous for our body. So sometimes that's all we do. We stop that, we take antioxidants, and the sperm count improves. Not for everybody, but for some. So lifestyle changes has an impact. Ovulation induction is the second route that we go to, and sometimes we do about 3 to 6 of these for patients before we move on to the IUI, which intrauterine insemination, which I explained. And if this doesn't work, then we go to IVF. And IVF, we can do even 6 cycles. But note that some patients, this is not the diagram, some patients with blocked tubes will have to go straight to IVF. Some patients with poor sperm count will have to go straight to IUI. So it's different for everybody. So everybody has their own treatment plan. So what are we looking for? What's the outcome that we're looking for? Hopefully not no pregnancy, but it is a reality. Sometimes there is no pregnancy. Sometimes we try and even do IVF and we still don't have a baby. Then what? We've tried and that's all we can do. We try our best. We give our clients hope. And sometimes the pregnancy starts, but at 7 to 20 weeks, the woman starts to bleed and she loses the pregnancy. Because even if she did an IVF cycle, it's still a normal pregnancy. So that's a miscarriage. It ends in miscarriage. Very devastating. And sometimes we are extremely happy because we get the result that everybody wants, a live, healthy baby. And at that point, we're all ecstatic. So this is the journey of somebody struggling with infertility. Yeah? Please put your shoes in that journey. Sorry, as I said. I don't know if this will play now because I don't know if there's Wi-Fi. But success, this was a video, and I'd like you, the media who are here, you have a very important role to send out the right messages. So this is a video of the first IVF baby that was, the first IVF baby sorry, I guess they're trying. So as they're trying, I can tell you what it's about. It's the first IVF baby that was made, 40 years ago in England. And it's a wonderful story of struggles. And it took many, many years for that baby to come up. But what I learned yesterday that was interesting is that the media actually bombed the hospital that the baby was born in. Guess why? Or somebody. We don't want to say the media, but people say it's the media. But it's because they wanted to have the first pictures. They wanted to sneak in and have the first pictures of that IVF baby of the world. And we do have an important role. We need to send the right messages as the media. I don't know if it's going to play, and if it doesn't play, it's okay. It's fine. I think it's okay. If it doesn't play, if you got no message at all today, I think I want to leave you with these messages. One is that we need to remove stigma, yeah? That infertility is a couple thing. It really does take two to tango. Two, which I didn't say, is that we do need to investigate. Not all treatments suit everybody. Patients need to come in, or the couple needs to come in, and we need to find out what the cause is. Three is that there are different treatment options. Some are simple, lose weight, and some are a bit more complicated, like IVF. But sometimes that's the only way. Sometimes IVF is the only way out. Three is support, support, support. And this is where this picture comes in. And this is where the media should assist, and each and every one of us. I'm sure everybody knows somebody who is struggling with infertility. We need to support. I put this picture up there very depictively because what I hear most from my clients is I'm stressed. Why? Because my mother-in-law doesn't want to see me. Because my sisters-in-law are trying to marry my brother off to a younger woman because we're not getting pregnant. Because my friends are always asking me, what's happening, what's happening? We as women are our worst enemy, I would say. I never hear my father-in-law. I almost never, really. So we need to support. And sometimes it's not just even the questions, it's poking at their belly. I've heard someone saying, my mother-in-law came and poked at my belly and asked, when is this happening? Or someone asking, you want to be so educated, you're just going out for all these degrees and not thinking about babies. Yet you don't know that that woman is actually trying and she's struggling. So please, let's be sensitive to these women. Let's be sensitive to these clients. Yeah, so we need to support, support, support. And I think the last slide is just the slide for sharing hope. Please put in the hashtags and let's share hope, because the only thing we should do as media, we need to create awareness, we need to advise, but we need to give hope, because that's what we can. And I loved what Dr. Rasha was about, because hope doesn't only come. There's some people who will never get their own child. But hope means that they can be now accepted in the society. Yeah? So hope, let's spread hope. Thank you.